We'll get started, and hopefully other people will trickle in on this dark night. I'm Meg Kameri. I am the Director of Student Services for Holliston. We, in sort of looking at one of our district goals around promoting and ensuring the safety and health of students and staff, we decided to bring to you a night where we're going to cover a couple of sort of new and recent topics, but really sort of at the heart of our continued efforts to support the whole child and support the community. I'm going to sit down and we'll have a casual sort of conversation throughout the evening. So for tonight, and I know we have an audience hopefully at home also watching and listening in, but for tonight we have invited 3 guests, and actually we will have a student leader join us later in the evening to talk about some student groups that have been actually very successfully implemented at Holliston High School and are now growing down to Adams Middle School. But for this evening, we have invited Dr. Tracy Gladstone from Wellesley Centers for Women. Dr. Gladstone has worked with Holliston schools for 2 years now. She's in her 2nd year. We had the pleasure or luck of receiving a 2-year grant from the Metro West Health Foundation, and in partnering with Dr. Gladstone, whose team comes in and supports the district, we are doing mental health screening of our adolescents. So a grade in middle school and then 2 grades in high school. The district hopes to continue to provide this screening and really do preventative mental health care for our students. The sort of 2 other major components of the partnership involve education to staff and then also to the community. So you're going to hear more from Dr. Gladstone later. Lynn Bowler is our nurse leader and the nurse at Miller Elementary School. And over the past 2, now we're going into year 3.
This is our 3rd year.
In the state of Massachusetts, the Commonwealth, school districts are obligated now to provide SPERT screening, and Lynn's going to talk to you a little bit more about what that looks like for Holliston Public Schools and how we are supporting and screening adolescents, so again, middle school and high school students. And then we're really excited to have Jackie Weiner, who is the Director of Holliston Youth and Family Services. Holliston Youth and Family works closely with the school district, but is a really unique and wonderful resource to the town in terms of providing support for children and families. So we're looking forward to hearing from all 3 of them. We will be joined later in the evening by the student leader from the Beautiful Mind campaign, and she'll speak a little bit more. But they have about, 100 plus kids at the high school. They're a part of the group, and they're really focused on destigmatizing the idea of mental health and how to support and promote good mental health for their peers. So without further ado, we're going to start with Dr. Gladstone. And for the sort of purpose of the conversation as we go through slides, I don't know if you want to wait till the end to take questions or what you're...
I'm actually happy to take questions as I go, especially we're such a small group here, and I want to make sure that you have a chance to ask me whatever you want to ask me. So I have material to present that will provide some general information about youth depression and suicidal behavior, and then we'll describe the program. But if you have questions as I go, just jump in and let me know, and I'll just pause whatever I'm talking about. Okay? So, Meg, you're going to just move for me? Oh. Okay, great. Okay, great. So I'm going to talk a little bit about, I'm going to provide some general information about depression and suicide, and then I'm going to explain the actual screening. I will tell you what some of the questions are, exactly how it goes in the classroom, and I will take any concerns you have, anything you want to discuss, just bring it on, okay? Because I really want you all to be comfortable with the program and make sure that everything that you need to ask is asked, okay? So there are 3 main goals to the Mood Check Holliston program. The first is to really enhance mental health literacy in the community. So that means doing programs like this, and we did programs like this last year as well, but really giving parents an opportunity to learn about depression, to learn how to recognize signs and symptoms in their kids, what to do if they're concerned about depression in their kids. We also do a staff training program. So last year in the high school and in the middle school, we did many educational sessions with all the teachers. We're doing them again this year, and all the special teachers, really all the adults in the school, so that so that kids, if they do recognize signs or symptoms of depression in themselves or their peers, they have many trusted adults that they can go to. And so the adults in the school will feel comfortable talking to kids about these concerns and hearing concerns from kids. Parent programming like this, and then student information sessions. So really providing students with information about depression and suicide, how to recognize signs, what to do if they're concerned, how to get help from adults in their community. And so that's the first kind of goal, is about mental health literacy in general. The second goal is screening teens. And so we do screen all 7th, 9th, and 11th grade teens in Holliston. But if you are uncomfortable with your teen being screened, then you just need to opt them out through the school. And so we've been doing this program in another community and in Holliston last year. And really, the very large majority of families seem comfortable with the screening program, but there are some that are not. And there has been no problem with kids being removed from the classroom, going to the library, going somewhere else in the school building while the screening is happening, while the educational programming is happening, without any stigma or any bad feeling on anybody's part. So it's not a problem if you're uncomfortable with the program and you don't want your child screened. It's absolutely fine to pull them out. We have been screening 98% of the kids. Really, it's been very well received. And even when there have been some concerns from parents, I'm really very willing to answer questions, and so generally we can talk them through, and if you're comfortable with it, that's great, but if you're not comfortable with it, it's absolutely fine as well. And then we do follow-up with all families. So we send follow-up information to families regardless of the outcome of the screening. So if the screening indicates that a child is doing just fine, based on the screening, then we communicate that to parents via email. We send a generic email that says, based on the results of the screening, we don't have concerns about your child at this time. It also provides information about signs and symptoms of depression, links, resources, phone numbers to call if you have any concerns at any point, and then our contact information. And we do hear from parents over time later on. Maybe their kids were doing fine at the time of the screening, but then they have some concerns later, and we hear from parents all the time, and we're very, very willing to take those calls and those emails. If there are any concerns, if you identify any concerns with your child, we contact you by phone. So we call you, we have phone numbers for everybody, and we reach out, we talk directly with you about what our concerns are. We tell the kids that we're going to talk to the parents ahead of time. We tell the kids what we're going to say to the parents. We say to the parents what we told the kids are going to say to the parents, and we work with parents to link to supports in the community and to make sure kids are covered. And then we follow up over time with any families that want that long-term follow-up. So we offer to circle back in a few months and check in and see how things are going and provide more support as needed. So that's a follow-up component. So those are the three main parts of the program. And a little bit later, I will talk to you more about actually how the screening looks and exactly what happens in the SOS sessions in the classrooms, exactly what information the kids get. Okay? So this is just really, I'm going to provide you now with general information about depression and suicidal thinking. And I'm going to go quickly because I don't have a lot of time and I want to make sure that you all can ask me questions. If I go too quickly, just slow me down. So basically this slide is just really talking about the literature that suggests that there is a real reason for doing general screening in the school setting. It's been done all over the country for many years, and it's been rated, it's been very well received by parents, by students. Teens rate school counselors as very useful to them. They're happy to have this kind of screening in school. Parents are happy to have schools doing it. And actually, teens prefer to receive this kind of connection through mental health through schools as opposed to a specialty mental health setting. So a lot of times kids don't want to go to a shrink's office. They don't want to go to get mental health support from a psychologist or psychiatrist, but they're more comfortable accessing those services through the school, and it has been found to be acceptable. Why an outside team? So this is a really important part of this. We come in, we are not part of the school, so we actually promise confidentiality to students and parents from the school. So when we talk about confidentiality with students, we let them know that we will not tell any teachers, guidance counselors, anybody in the school the outcome of the screening, but we do tell them that we will talk to parents and guardians. So we let them know that if we have any concerns, if we are worried about them in any way, we will touch base with their parents or guardians. And by worried, we explain what worried means. So we say if we're worried that you might be depressed, might be at risk of being depressed, might be struggling with suicidal thinking, might be at risk of harming yourself or harming somebody else or being harmed by somebody else, we will contact your parents or guardians and talk to them about it. So kids know this ahead of time. We always think that this is going to make kids not tell us what's going on. It doesn't. They tell us. They tell us anyway. And I think part of it is that we are an outside people. We're generally kind of nice. We sit, we chat with them, and we don't, a lot of times kids and parents too are concerned about somebody in the school knowing what's going on with them because they want their privacy, or they're worried that a guidance counselor, if they find out about it, is going to be writing them a college recommendation and say bad things about them. These are all the kinds of things we hear from kids and parents, and we are able to offer that confidentiality. So I think that's a really big advantage to having an outside team coming in and doing this work. So this just gives you a sense of the problem of depression. At any one point in time, 3 to 8% of kids will meet diagnostic criteria for major depressive disorder, but as many as 20% of kids will be experiencing significant depressive symptoms throughout adolescence, and the average age of onset is about 15. So when you're looking at preventive efforts, people really suggest that you start a couple years before that. When we first started this screening program in another community, we were working in the high school, and we were told by many people, students and parents, you need to go earlier. The high school is too late. And I can tell you we've been for the past couple weeks in middle schools in another community, and we have been, there's a lot going on in middle schools. So it really does seem, targeting 7th grade seems to be a really great place to be starting, just to start that early. And it's really, the relapse statistic is something I always like to highlight because, even if somebody develops an episode of depression and they recover from it, so a teen might develop an episode at age 15 or 16 and they're doing okay, they recover, they get treatment, and they're doing fine. More than half of those kids within a few years will have a relapse. So once the depression begins, it can be a chronic episodic illness. So if we can start to catch kids a little bit before that actual episode sets in, the idea is to sort of change the course for them and prevent them from actually ever starting that long-term problem. So that's a little bit of a funky slide, but when I talk about symptoms of depression, I like to talk about them in different categories. So I talk about the psychological symptoms. I'm not really sure why it is that way, but it's okay. The behavioral symptoms, and so some of the psychological symptoms. Depressed mood. So you think about depressed mood. When you think about depression, you think that somebody seems really sad all the time. It's just as often in teenagers that depressed kids will look really irritable. So they'll be really fighting with you all the time, fighting with their peers. They seem really oppositional and unpleasant. That's just as often how depression looks in teenagers. You'll often see a lot of anxiety, nervousness in kids that are struggling with depression. They have trouble with concentration. They have trouble with motivation. They're sometimes really perfectionistic, really indecisive. So these are just these are not all symptoms on the diagnostic checklist for depression, but this is how a depressed teen might look. Want to go to the next one, Meg? So behavioral symptoms. So you'll sometimes see crying spells. You'll see that they're not as productive. They withdraw from their friends. Something that you see a lot in somebody, a teenager who's struggling with depression, is that they don't want to do the things that they generally like to do. So a teenager who suddenly doesn't want to see friends anymore. Somebody who generally likes to be social doesn't want to talk to their friends on the phone or go out with their friends anymore. Or somebody who's really into swimming doesn't want to go to swim practice anymore. And it's important to remember that we all sometimes have times that we don't want to be with other people, or we all don't want to go do what we're supposed to do. But it's really when you see a clustering of these symptoms and it lasts for a couple weeks, that's when I get concerned. So having somebody who just is a little bit grumpy or irritable and doesn't want to go to practice or doesn't want to, clean up and shower right away, that doesn't really worry me. It's just if you see a lot of these things lasting, that's when you worry. And then the physical symptoms. And a lot of times in kids, depression can look physical. So kids will be really tired. They'll complain about stomach aches or headaches. They'll have a lot of problems with sleeping. Sometimes they're sleeping too much, and sometimes they're not sleeping at all. There'll be a change in their appetite. So you'll see kids they're not hungry anymore, or they're overeating and gaining weight. They'll complain about heart palpitations, muscle tension. So these are just some things that you will often see. Something that I see in kids who I worry about are kids who generally will take really good care of themselves physically. They'll like girls who will dress nicely and put on makeup every day and suddenly they're not taking care of themselves, they're not showering as much, they're not taking care with their appearance, that's to me a really a sign that something is amiss. And again, if they stay up late one night and they don't shower the next morning, it doesn't worry me. But it's just if they're not taking care of themselves over time that I worry. And this just gives you a sense of how depression might look different in your teen than it might look in an adult that you know. So certainly more irritability and agitation among kids who are struggling with depression, more somatic complaints. They seem really touchy a lot of times. Inattentive to personal appearance, as I mentioned, withdrawing from social activities, and also more risk-taking behaviors. Those are just some general signs. I want to mention protective factors. Before I talk about risk factors for depression, I want to talk about protective factors because there are a lot of things that communities and families can do to support kids and help keep them healthy. So kids who have strong problem-solving skills, a strong peer support system, that are involved in activities, that have close relationships with their family, close relationships with adults outside of the family, so close connections with coaches or teachers or their friends' parents. Those are all protective factors for depression. And then when I talk about risk factors for depression, I like to talk about specific and nonspecific risk factors. So the nonspecific risk factors are associated with a whole bunch of problems. So kids who are living in poverty or exposed to violence, have severe life stressors, they're at risk for depression and a range of other problems also. But specific things that are linked to depression specifically are things, certainly there is a genetic component to depression. So this is not to say that all kids with a depressed parent will become depressed. And in fact, most kids with a depressed parent do just fine and don't become depressed. But kids who have depression in their family are at increased risk relative to kids who don't have depression in their family. Negative cognitive styles have been associated specifically with depression. And by cognitive style, I mean the way that kids would think about events that happen in their lives. So if a negative event happens, how they would attribute that event. If they would attribute it to really personal things, they fail a test and they say, I'm stupid, that's a negative cognitive style. If they fail a test and they say the test was unfair, it was too hard, that's a healthier cognitive style. So that's what I mean by cognitive styles. Certainly being female, girls beginning in adolescence through adulthood are about at twice as much risk for depression as boys. That doesn't mean boys aren't depressed. Lots of boys are depressed, but more common among girls. I just wanted to put up a slide that just talking about LGBTQ youth because these kids are at an significantly increased risk for depression. So they have about twice as high a risk for depression and suicidal thinking than non-LGBTQ youth. They are more likely to make suicide attempts. They are more likely to report abuse by their peers. They are less likely to receive treatment, mental health treatment. So it's just a significant risk factor that I think it's helpful to be aware of. And consequences of depression. I mentioned that that depression is a chronic episodic illness. So kids who develop it, in adolescence are more likely to have problems long term. And so you see, in the short term, you see problems with peers and family. These kids aren't doing as well in school. They're more likely to express suicidal thinking and engage in suicidal behavior. And then long term, they certainly have poorer functional outcomes in adulthood, more missed days of work, lower educational attainment, higher rates of suicide attempts, more likely to be hospitalized. So when I initially started this program, I really was starting a depression screening program, and I want to make it clear that suicidal thinking and behavior and depression are not the same thing. So there are many people who struggle with depression who are not struggling with suicidal thinking or behavior at all, and there's many people who are struggling with suicidal behavior and thinking that are not struggling with depression, but they do often overlap. And so because thoughts of death and suicidal thinking is a symptom of major depressive disorder, we ask questions about suicidal thinking when we screen for depression, and so I think it's important to talk about risk for suicide in the context of talking about risk for depression. So certainly more than half of teens who completed suicide had a mood disorder at the time, like depression, but that means that about half the kids didn't. So they overlap, but they're not completely overlapping. So Your role in taking care of your kids around depression, I think that it's really helpful for parents to know the risk factors and to know the signs and symptoms of depression, so that if you notice things in your kids that concern you, you can ask about them. And I think a lot of us are afraid to ask our kids about how they're feeling, about depression, about suicidal thinking, and we often think that if we ask that question, then we might give our kid the idea to try something. And it's really important to know, the literature shows time and time again that asking your child if they're thinking about suicide is not going to make them consider suicide. It's a really important thing to know. It's really okay to ask. And the reality is that if you ask a child who's not thinking about it at all, they'll say no. And if you ask a child who is thinking about it, they're going to be glad that you asked them, because most people who are struggling with suicidal thinking don't want to be, and they want somebody. They give most people who actually end up, not all people, but most people who actually end up committing suicide have given clues along the way. We just don't see them because we don't know what to be looking for. And so it's really important to ask the question, if you are uncomfortable with how your child's doing, or another child in your life, you think that they're displaying behaviors that worry you, then ask them. Say, when you feel this bad, do you ever think about hurting yourself? Do you ever think about taking your life? And I assure you that if they're not thinking about it, they're not going to suddenly have the idea. So I think if your teen is showing warning signs, especially of suicide, I'm going to talk about what some of those are, then you want to respond immediately. You want to take it seriously. You want to get your teen some support. You can seek resources in the school and in your community. And one resource that we have as part of this program is access to the Interface Referral Network. And I really want to put in a plug for that referral network, because it's a wonderful resource that I'm not sure that a lot of parents know about. But anybody who has had a teen struggle, or themselves struggling and needing to work with a therapist, it's very, very hard to find mental health resources in the community that will take your insurance. Insurance is a huge obstacle for many people, and then have availability. Sometimes there's wait lists to get in to take your teen to see somebody. And the Interface Referral Network, this program, this grant that Meg mentioned, pays for the Interface Referral Service. So you can call, and I can actually, I don't know the number offhand, but I'll just look it up for you before we leave. But you can call this number. It's not a hotline, it's a helpline. But you can call them Monday through Friday, 9 to 5. A clinician will answer the phone. You can tell the clinician what you're looking for. I have a 15-year-old girl who's just hasn't been seeming like herself, and I'd like to connect her with a therapist for an evaluation and possibly some therapy. And the clinician will ask you about your insurance and, any language requirements, any time of day requirements for an appointment, and they will match you with a therapist that has an opening and that will see your child. So it's a really wonderful resource. It takes a lot of the legwork out of connecting with mental health resources in the community, and really makes people much more accessible for you all. So if you have a concern about your teen comes to you with concerns about themselves, you have a resource that you can get them some help right away. The other resources, your school is certainly a resource if you're comfortable going to the school. Pediatricians are tremendous resources. Pediatricians have broad networks of mental health providers that they routinely refer to. They can kind of do an immediate evaluation if you need that. They can help connect you to somebody who can see your child right away. So it's just another resource if you're feeling like not sure what to do and you don't want to go through the school. You have that as a resource as well. So how to recognize suicidal thinking in your teens. Certainly listen for verbal cues. So if your teen says, I wish I were dead, what's the point of going on? You'd be so much better off without me if I wasn't here. I'm not telling you to panic if you hear this from your teen or from other children in your lives, but listen to it. If you hear kids saying these things, then you need to take it seriously and ask them what they're thinking, what they're meaning, express concern, and take them for support right away. Okay? So this is just, I put this slide up. The basic point of this slide is that really anything you say is okay. Any way you ask is okay. On the very bottom there, I always put that as something I wouldn't want you to ask. If there's one thing not to say, it's that you're not thinking of killing yourself, are you? Because if you say that, you're communicating, the subtext of that question is that you don't really want to hear that might be what they're thinking. But aside from that, However you ask, this just gives you some different words, but however you ask is really fine. And none of these questions are going to make somebody think about hurting themselves. And all of these questions are going to give somebody permission to express what they're feeling to you if they are having a really hard time. I put up a slide about cutting because cutting is not uncommon, and it is a significant risk factor for suicide, but very, very often kids who are cutting are not, this is not a suicidal gesture. So often kids are cutting. You hear kids, when you talk to kids about cutting, they'll say, I was feeling so numb, I was trying to feel something. So you hear that a lot. Sometimes kids just don't know what to do with these intense feelings that they have, so they think that this is going to release some of it, and it's going to help them to feel better. So it's not, even if it's not a suicidal gesture, it's really important to take cutting seriously, because what it's telling us is that kids don't have a better way to manage these really strong feelings. Sometimes it's anxiety, sometimes it's depression, but they don't know how else. Anger, they don't have a healthier way to express those intense feelings. So if you do notice your child is cutting, it requires intervention right away. And you know, sometimes you'll see kids, they'll have scratches on their arms. You'll see on a really hot day, you'll see kids wearing long sleeves, and they'll be holding on to their sleeves to keep them, to keep their arms covered. So if you notice, if you're worried, school nurses are a great resource about cutting, because they're really great at having kids show them what they're seeing. As saying, show me your arm, and kids will do it for the nurse. So it's also a really good resource if you're worried about your child. You call the school nurse and say you're worried that I think my child might be cutting, and let the nurse kind of help you to see anything. I hope it's okay that I'm saying that. Yes. Yes. Yeah. Okay. Mm-hmm. I just want to mention that there's a lot of really great treatments for adolescent depression, and they have a strong evidence base. So we really do have evidence that their medications work well, talk therapies work well, cognitive behavioral therapy works well, and most kids do better if they get evidence-based treatments. But the longer you wait, the less likely they are to work. So sometimes we have this idea where, we get worried about our teen, but then we say, oh, it could just be normal developmental stuff. I'll give it some time. And then you wait a while, and then it escalates a little bit. And then by the time you try to get them treatment, you have a waiting list to get them into treatment. And at every turn, you're decreasing the chances of that treatment working. So if you are worried, jump on it. At worst, you get them in for an evaluation too soon, and they don't need it. So then you have that connection with somebody. So if they do need it later, you know where to take them. So why is prevention important? Well, as I mentioned, with relapse rates so high, if we can prevent the initial onset of a depression, we're really setting kids on a much better course. And there is good literature suggesting that prevention can work. So prevention efforts can really keep kids from developing that first episode. So even kids who are symptomatic but not really meeting criteria for full-blown depressive disorder, but they're struggling a bit, if you get them some services initially, you can maybe prevent that from kicking in. So the Signs of Suicide program, this is the part that we do with kids. This is sort of the educational piece for your kids. And essentially what it means is that we go in, we give the kids an anonymous kind of questionnaire at the beginning, just to ask them what they know about depression already, so that then we can determine if we're teaching them what we're hoping we're teaching them. So that's anonymous. The kids fill it out, 10 questions of what they know about depression. Then we do a program, and then we ask them to fill out the same page again at the end to tell us if they've learned what we're hoping that we've taught them. Then we have an educational video. So the Signs of Suicide program has a separate video for middle school, for middle high school, and then for later high school. So depending on what grade your child is in, they'll see one of these videos. And the videos, if anybody feels that they want to see what their kids are going to see ahead of time, you can just let Meg know. She has all the videos and can set up a time to show them to you. They're anywhere from 20 to 30 minutes long. I think they're quite good. Essentially what they do is they go through the symptoms. They teach this ACT idea, ACT. So A is to acknowledge that you see signs of depression in yourselves or a peer. C is to express caring or concern. And then T is to tell a trusted adult. So the message really is that you don't have to handle your friend's depression yourself. That's too much for you to handle. And there are many adults in your life that can help you to help your friend. And it really does mostly talk in terms, especially the younger two, the 7th and the 9th grade videos, talk a lot in terms of noticing this in your friends. The idea being that it's easier to talk about your friends than it is to talk about yourself, but kids will learn the signs and symptoms whether they're talking about their friend or they're talking about themselves. And so it goes through scenarios where it has kids exhibiting signs of depression and how their friends react to them. And then there'll be a scene, and then a yellow sign will come down, like a street sign that says wrong. And then they'll replay it in the right way. And initially when I saw this, I thought, that's kind of harsh, to tell kids that they're doing it wrong. But actually the literature has shown that when they did focus groups with kids, they wanted to be told wrong and right. They don't know the best way to respond, and so they need somebody to kind of be very clear about how to respond. And so it does a really nice job of showing sort of reasonable reactions and saying, it's okay if you've reacted this way to your friends in the past, we're all here to learn, but this is a better way to do it. And so showing kids expressing concern for their friends, taking them to a coach or a teacher or a parent or a trusted adult of some kind. And so we show the video, we have a group discussion, we go over what the ACT is, we go over all the signs, symptoms of depression, we go over why it's important to show caring and concern and how to show caring and concern. We go through a list of trusted adults that they could go to. We talk about what happens if they take somebody to an adult and the adult says, that's just typical, don't worry about it, to go to another adult. We talk about going with your friend to an adult, how to support your friends. So we walk them all the way through the message of the video. And then we talk about the mood check program. So we talk about the screening. We explain confidentiality exactly the way I explained it to you, that we will not share anything we learn with the school and unless the parent and the teen want us to. So we, if often a parent will say, yes, tell the guidance counselor because I want somebody to check on them in school. We encourage that. We think that's ideal. But we know sometimes parents don't want that to happen. So we explain confidentiality to the kids, and then we give them a screening form, and it asks them about how they've been doing in the past 2 weeks. So a series of 10 questions about the past 2 weeks, and it goes to the symptoms of depression. Have you noticed a change in your appetite? I think if you actually scroll through, okay. So this is a self-report. In the past 2 weeks, have you been feeling down, depressed, irritable, or hopeless? Have you had trouble with concentration? It goes through about eating and sleeping, and it asks about thoughts of death in the past 2 weeks. And then there's a couple additional questions that ask about depression in the past. And then at the bottom is a question that asks about, it says, if you would like to speak with somebody right away about yourself or a peer, fill in this bubble. Check yes or no. So based on what kids write on this screening form, we call kids individually to meet with them. And we are really careful to explain during our program the many reasons why we call somebody. So today I screened a class of 20 kids, and I called 10 kids down to see me, so half. So it is not, and we say over and over, do not assume if you are being called down or your friend is being called down that we think they're depressed. So if we call kids down, and we say this to your kids, we call them down if we're worried that they might be depressed, if they didn't fill in a bubble. I mean, most of the kids, they just leave a bubble blank, and we are relentless. We call everybody down if they miss a bubble, as much because we want to make sure, sometimes it's not even a very important bubble, but we want to call a lot of kids down so that we aren't stigmatizing anybody by calling them down. So we call them down if they miss a bubble. We call them if they just, we call kids down for past depression. So there's a question that says, there's been a time in the past when I've struggled with depression, and tons of kids write yes. And then we call them down and they say, well, my grandfather died 5 years ago, and we're sad about that, but we're not worried that the child is depressed because their grandfather died 5 years ago, because everybody is sad when their grandfather dies. But it gives us a reason to call kids down, and then we call kids down if they check that they're concerned about themselves or a peer. So a lot of times kids are saying to us, I'm worried about this person who's in my English class, or I'm worried about a friend who lives in Virginia, or I'm worried about a child in another school in this town. And so we can follow up with that child or that parent and kind of check in on that. And hopefully the person that they're mentioning, we've also screened as having trouble. But this is all to tell you that there's any number of reasons we call kids down, and we're really careful to go through all of these reasons and to explain this to everybody so that we can destigmatize it as much as possible. And then we call kids down one at a time, and we meet with them one at a time. And if you go to the next slide, we do.
You mentioned you did this all on the same day, so they did paper screening and then meeting with you within.
Yes. So, yes, we do our best to do it in the same day. And certainly anybody who puts anything down, we kind of triage the forms we get back so that if we get anybody who's given us back a form that's talking about suicidal thinking at all, we will see them that day. And that's why we actually don't screen at the end of any day. We do all of the screening sessions earlier in the day so we have enough time to make sure that anybody who's really having a really, really hard time, we can get to right away. And then usually within 24 hours. So if we don't get them that actual day, then we'll have stragglers the next day, and sometimes the next day will be the kids who had a past depression, and sometimes it is a past significant thing, and then we ask them more questions about it, and we'll touch base with parents about that also if there is something significant, but a lot of times the past depressions are not so significant. I was really bored for a week in the summer, and so I felt kind of sad, and so we don't really worry about that. But we do this individual interview, and so we begin by, there's 3 parts to the individual interview, so we will look into whether or not they may meet criteria for a current major depressive disorder. So we kind of do a more in-depth interview about the depressive symptoms. If they endorse any suicidal thinking on the screener form, or as we do this interview, it kicks us into a whole protocol where we ask a lot of questions about those suicidal thoughts, how often they are, how severe they are, so that we can really evaluate what the risk is. If there's any current safety risk, we want to address that right away. And then we ask about past depressions as well, because we know that kids who have had a depression in the past are at increased risk for having a future depression. And pretty much if we go through this whole interview, we call parents. Sometimes I went through a whole interview with a 7th grader just this week who on the initial screening form had a bit of we have a low threshold, so he was a little bit high. But then when I met with him, he looked great. And there was not, and as many times as I asked, in as many ways as I asked, I really couldn't come up with anything. So I called his mom and I said, he really seems fine to me. But because I didn't want him to go home and tell his mom that he had met with somebody and then me not talk to the mom. So we are pretty liberal with when we reach out and call you all. And a lot of times we call and we just say, I'm not worried. We give you a sense of how worried we are. This is what I would do. I would probably try to find a therapist. This is how I would find a therapist. Or if it's something more emergent and we're worried about suicidality, then we'll help you to connect with emergency services in town where they can do an immediate evaluation. You can bring your child that day to have them evaluated without going to an emergency room, so we'll help you to arrange that. Or we can arrange to have somebody come to the school if a child is really struggling and have them evaluated at the school. So there's all kinds of things we can do to kind of depend on the severity of what we're seeing. And I'm not going to go through these things. I'm going to just tell you that we've been doing this program for about 4 years now, and we really have I constantly add stories that I could share with you of just situations where, kids were really having a hard time and weren't telling people, and somehow having a friendly outside person really just ask the question has really helped them to talk about it, and we've really been able to connect a lot of kids. So sometimes we are finding kids that nobody even knows about, kids who are really struggling with depression or even suicidal thinking and behavior, and they haven't shared it with anybody, and we're able to we have to tell parents for the first time, and they've really never heard this before. Sometimes we're finding kids who parents thought were doing fine. So they were in treatment, they stopped treatment, parents thought they were doing really okay, and they're actually not doing okay, but they haven't wanted to tell their parent again. Sometimes we find kids who are transitioning to something like a different school year or a different semester and are really having a hard time, and we're able to sort of cue parents into that. So we definitely, at a middle school in a different town, I did a training with teachers, and immediately afterwards, a teacher went to a guidance counselor with concerns about a child after I'd gone through all the signs and symptoms, and that child ended up hospitalized that day. So sometimes, it's just knowing what to look for, and asking the questions can get kids to really come forward with what's going on with them. Just a lot of them. And so So for follow-ups, I mentioned this already, that we do contact everybody after we screen your child. So, and we are pretty persistent. So we're persistent both in getting the kid. So if your kid is absent, we'll come back and get them. We'll pull them out another day and screen them. Like we have a list of everybody who's supposed to be screened, and doggone it, we screen them. And we do contact parents, and we are pretty persistent with parents. So, sending an email is easy. So if the child is screening with no issues and we send what we call a healthy email, we just send an email, and if you want to reach out to us, that's totally fine. But if we don't, if we don't send you a healthy email, then those generally go out the day or the next day, but generally the day we screen. Then you'll hear from us. And we call in the evenings. We give out our cell phone numbers. We call until we reach people. We call moms, we call dads, we call at work, we call cell phones. We track you down so that we can, because we want you to know what we're finding, and we don't want you to worry. So we really do our very best to get in touch with you in any number of ways. And then we offer referral services, and we do offer follow-up, as I mentioned. This just gives you a timeline, and that's about it. So, questions? What can I tell you?
Do you screen everyone in one grade, like compared over a day or a couple of days?
So we screen an entire grade, and generally in 2 to 3 days. So when we have been I don't want to say less successful, sweatier when we try to do it all in one day, right? Because then we're finding a lot of kids, and then we don't have enough time to get kids in real time, and we don't want to ask a question and have a child talking about something pretty significant and then not immediately touch base with that child. So we generally are doing it over a few days, and the Holliston grades are relatively small. So like we're planning to be in the 7th grade next week, and we are planning to do it over, I would say 3 or 4 days we should be done. What else? Do y'all have any concerns about this? I want to answer questions. I don't want you to feel...
My daughter did it last year, and I remember reading the questions before. And yeah, it was good.
Okay.
Very good. Yeah, it's so important that it's in the schools right now.
Certainly the literature is suggesting that all kids be screened every year from grades 6 through 12, and screened especially if there's a place to refer them. So it's not really very helpful to screen anybody if you don't have a place to catch them, right? And that's why we really try to do that and connect you with the referral sources also. But pediatricians try to screen, and some do and some don't, and some do a better job of it than others do. I know when I take my kids to the pediatrician, and I like to think of our pediatrician as being like really savvy with mental health, they give me, I have a 17-year-old next to me, and they give me the form to fill out about my 17-year-old, which of course, So I think that pediatricians there's a range of how well pediatricians are managing this, and how seriously kids and families are taking it when they're at the pediatrician and they've got a million forms, and there's like a teenager, and then there's babies all around. And so I think that doing it in the school, I think it's a really great, it's where all the kids are, and it's an opportunity to really touch base with everybody individually.
Kind of intrigued by the referral program because I had some questions for my daughter, and I reached out to the counselors to get a list of psychologists, and as you had mentioned, I either didn't hear back, they all weren't taking new people for at least 6 months to a year, things like that, and I was like, okay, now what do I do?
It's really hard. It is. It's really a challenge, and I feel like as much as we try to talk about it in the community, that people don't necessarily know it's there or really use it, but it's a wonderful resource because they really will work with you, and they actually will follow up. So they'll make a referral, and then they'll call you back and say, did you go? How was it? Did you like it? If you didn't like it, we'll find somebody else. So it's really a collaborative process, and they have a very significant database, and they work with people, the providers and families all the time. So I have not ever heard of anybody who has been unhappy with it.
Great. Well, I think if questions come up later along, Dr. Gladstone's here all evening to help us. We are going to transition then to Lynn Buller, and as I said before, Lynn is our nurse leader over at Miller Elementary School. She's been in Holliston for many years. Lynn helps sort of coordinate with me the implementation of SPERT, which she'll get to in terms of a mandated screening in terms of actually adolescent care for children as well. So Lynn, it's all you.
Hello. So yes, this is SPERT. We call it SPERT, and it's screening, brief intervention, and referral to treatment. And this all came about back in March of 2016 in response to the heroin and opiate epidemic that was going on in the Commonwealth. And Governor Charlie Baker at that point signed into law, and it's called an Act Relative to Substance Abuse, Treatment, Education, and Prevention. And there were many components of this law, but several directly impacted schools, both public schools, private schools, charter schools, all across Massachusetts. So one of the points is it requires schools to have a policy regarding substance use prevention and the dangers of substance abuse, which we do have in Holliston, and that was completed in August of 2016. And then the second part is the schools must utilize a verbal screening tool to screen students for substance use disorders annually at 2 different grades. So that's what we're talking about is SPERT, and that's attending some of the regional nurse leader meetings. We knew this was coming down the pike eventually. We had heard about it before, when it was signed, so we felt at Holliston we were pretty prepared, and spoke with our superintendent and Meg and let them know what was coming down and that it was a mandate and had to roll out by the school year of 2017-18. So we did a lot of legwork, but what SPERT is first of all, screening, and it's a verbal screening tool. So sometimes the kids will get a little confused, or they're being screened for substance use and substances, and they're thinking urine testing, blood testing. No, we don't do any of that here. It's all just a verbal screening tool, and what we use is the CRAFT 2, which is an evidence-based tool. It's been being used since 1990. It's approved by the American Academy of Pediatrics. The DPH this is the tool that they recommend across the state as well. So then we do brief intervention, and and I'll go into some of our training, but we are all trained in motivational interviewing. So when we sit down with the student, we use this technique, mainly putting it in their court. We want it to be just a nice conversation. We want to help guide them in some of their decisions and applaud them for good decision making, and that's what that motivational interviewing is all about. And then we will refer if we feel there are significant risk factors, and I'll get into that a little bit more. But the purpose of the whole program is to promote prevention. We have found that the punitive model has not been working. It just doesn't work. So we want to get in there ahead of the issues, do some prevention, identify some early risk factors with these kiddos, and then take some actions as needed. So what does it look like? Well, we first had to identify who we were going to screen. The law states that we have to screen 1 middle school grade and 1 high school grade annually. So we kind of are comparing it a little bit to our mandated screening every year. We do vision, growth, postural screenings, and all that. So when we talk to the kids, we'll say it's another universal screening, and it's everyone. It's everyone in the grade is screened, and I'll get into that a little bit more. So what we did is we looked at our Metro West Adolescent Risk Survey. We talked amongst ourselves, administration, nursing, and found out what is the best grades to be screening at Adams School and then at the high school. And we have decided on the 7th grade. Mainly the screening tool is not developmentally appropriate for under 7th grade, so we weren't going to look at the 6th graders. We saw 7th grade was the best grade, and then again our 9th graders is what we're screening. So all the information and that we talk to the student about is totally confidential, and when they sit down with us, we let them know everything you say to us is totally confidential. So please be honest when you're talking to us. We try to do a little, how you doing? I remember you. Just a nice, easy conversation. We want them to feel as comfortable as possible. And then what we also do is make sure the parent know as well that it is confidential, and the only time that we would break confidentiality would be in the case that the child we felt was an imminent harm to himself or others. and that we are very clear about. And all parents, both at Adams and the high school, are notified through administration prior to screening, letting them know what's coming down the pike. And parents can opt their student out if they feel that that's what's best for their child. Also, the student, when they sit down with us, if they sit down and say, you know what, I don't want to do this, that's totally fine. They can opt out. And then once we do get the results from the screen, all these results are reported to the Department of Public Health. I take all the results, again, all totally confidential. The only thing that they ask for are the results, the grade, the age of the child, and who did the screening. And we use our guidance counselors and nurses right now.
Lynn,
So-
this might be a little further along, but do you want to explain why it is a health-related screening, and then sort of why we chose such staff to do the screenings then?
Right. As far as health screening, we find that the nurses know the students quite well if they have any underlying health situations. Our asthmatics are a little bit more in a position for if they're smokers, or, the bronchitis, marijuana, we and our diabetics. So we kind of feel like we have a little bit more background information. And our guidance counselors as well, we decided on, because they have great counseling skills and know the student population pretty well also. So how did Holliston prepare? There's been lots of trainings through the Department of Public Health. I attended an SPERT information session, brought that information back to the district, and then all the Holliston nurses also attended the training, and then we brought in all the Adams and high school staff, which would be all our guidance counselors, our school psychologists attended, our administrators attended. Those that were doing the full screening, in other words, actually screening the student, would be there for a full day screening. The administrators would come for a few hours to hear about the background of the program. So everyone that is screening has been through total training and motivational interviewing, a little bit about signs and symptoms. So we feel like we're all in a good place and comfortable with it. After that, the nurses all sat down and planned the logistics of the screening. There was a lot of work as far as thinking about questions that might be posed to us. How do we respond to that? How do we keep the kids interested and comfortable? What do we do? And we'll go into a little bit further. We have to find providers. Once we get this information, if we find kids that are at risk, what do we do with this information? We do have adjustment counselors at the high school and the Adams School, and that is our first line of a referral. And again, we refer only if the student agrees to it. Everything is confidential. If it's a low risk factor, we might try to get them to come back and talk with us, talk to the adjustment counselor. But we also went outside. I went outside and looked for people in our local communities, our treaters or providers that deal specifically with adolescents and substance abuse. And it's not an easy find. But we did find several in the area that do work with us. What we have found, and we're kind of in line with the rest of the state, our referral, the point of SPERT is trying to get to it before it's a big problem, before we see an influx in risky behaviors. So our referral rates have really been 1% or less. And we're in line with the rest of the state or less. So, again, what happens is letters go out to the parents. They are told all about it. They can opt out. And then there's student assembly. So the kiddos know that this is going to be happening. So they have questions as well. And they can answer all their questions. So we started this back in 2017 with our 7th graders. And then we did a full 9th grade and 7th grade last year, and we're doing our 7th graders actually tomorrow again. So what does it look like? We have the best made plan is we have 3 counselors and 3 nurses, all trained, and they meet privately. At the high school, we have separate rooms, all in the guidance suite. The kids come down just alphabetically and just sit behind a closed door. They're assured of all the confidentiality. We please encourage them to be honest. And do we think they're all telling us the truth? Probably not. I mean, we do our best, but you know what? It opens up a conversation. It gives them to know that there's people out there that can talk to them. It gets them thinking about it. So that's the big thing. So the student is asked 4 questions about substance use over the last year. such as in regards to alcohol, marijuana, that type of thing. And if they report no to all questions, we're done with the screening. We applaud them. We say, good job, you know, making good, healthy decisions. That's great. You're an athlete. Keep up the good work. It's just helping to be positive, making good decisions and awarding them for that. If they have a yes response in any of the first 4 questions, then we go on with some more direct questions from the craft screen. And if they have any days that they have engaged, then like we said, we kind of stop. We use some of our motivational interviewing skills and say, well, geez, you've done this on a Saturday night. Why, you chose not to on a Monday night? What was the difference, and why did you choose that? And you were with some friends, and we always give this scenario. At least I like to give this scenario with our 9th graders, especially. Once you start to drive, or your friends are driving, and put the scenarios in their head that they're going off to a hockey game, and they're with their friends, and then by the end of the game, you're realizing you don't want to get in the car with the student that drove you. Think about how would you handle that situation. Think in advance. You go to a party and it's really uncomfortable. So we kind of put thoughts in their heads about how to handle situations. So any students that do answer positively for 2 or more questions, we will try to refer, and again, they need to agree to referrals. If they're in imminent danger, that's another story all on its own. We choose not to screen on Fridays just because it makes no sense. If we're really concerned about a student, we don't want a Friday, to be honest, and be stuck. A full screening takes, we say 5 to 15 minutes. For a student that screens negative for everything, they're in and out within 3 minutes. And then we collect all the anonymous data at the end of the screening, and then I will go in and send that all off to the Department of Public Health, which is great. So then hopefully we'll get some information back and find out if we're going in the right direction. So this, and I do have cards over there, Meg. Mm-hmm. This is a little like a little gift at the end of a screening, and it's about a brain image. And what it shows, and we spent a little time going over it, it shows the effects of heavy drinking on a teen brain. And we discussed that that's a slice under MRI screen on the left of a student that's taking a test. And all those pink areas, red areas of the brain are showing all areas of the brain that are working, helping them answer the questions, brings facts to it, say attentive, etc. And then the other slice of from MRI on the right-hand side is from a student that is a heavy drinker, taking the same type of test, I'll say, and only one little area of the brain is actually helping them answer those questions. And I like to tell them that, and all of us have had plenty of knowledge in addiction and all that, but the adolescent brain is like a sponge. And, with substances, it can alter the neurological makeup of the brain and cause permanent damage, especially for those that engage in heavy drinking, heavy drugs. It can change the way they're able to perform, memorize, attend their sports, and the whole bit. And it's really interesting because this take home, they really take a look at that, and it really hits them hard. And
you mentioned that's distributed to all the students.
Every student goes out with that. And it's interesting. We know that we hope we're hitting the right grades, but when they come through, and this was the first year we did our 7th graders 2 years ago. We did the same grade just recently, the 9th graders. So it was our second time around with that particular grade, and we feel like they've got good questions. They'll ask if we're talking about, geez, have you taken any medications that you shouldn't have? And they'll say, well, geez, what about that ibuprofen? Or geez, so they're asking, and they're young and they're naive in a lot of ways, which is great. But they're asking these questions and they're thinking about it, and having established people that they can talk to, and it's a good way that they know they can always come back. And we always say your nurses are here, counselors are here, your pediatrician is there. If you ever have any questions or concerns about yourself, a family member, or anyone, a neighbor, there's always someone you can talk to. One of the questions that we do ask about is about getting in a car, and are you ever felt at risk? And many times we hear from our students, well, geez, We went to Bertucci's and Mom had a glass of wine. Should I have gotten in the car? And we'll immediately say, well, did you feel safe? Because that's what it all comes down to. But, things have come out of all this, and I think we are managing to make headway. We hope that we're hitting the right grades, and we believe we are.
What made you do 9th grade as opposed to 10th?
What's that?
What made you choose 9th
Because we
grade?
find by 10th grade, there's an influx in the risky behaviors. So we want to get the grade before.
Do you think you would ever add a 3rd grade into it, or is it a financial reason that we only do 2? And it's mandated to do 2?
It's mandated, 1 middle and 1 high school.
Would we ever
It's
do-
probably a time constraint as well. And I'm sure we'll be looking at it again. This just rolled out 2 years ago. Actually, the 17-18 was the full first school year. So we're just now compiling data, and we'll take it from there.
That's a great question in terms of conversation with our administrators. I mean, when we even try to navigate through, so for example, the mood check essentially is not a mandated one, but it's something that Holliston's really committed to in terms of preventative care. SPERT is a mandated one, and then along with all the other mandated health screenings.
Yeah.
So when we meet with principals to figure out when are we going to do SPERT, when are we
Right.
going to do mood check, when are we going to do scoliosis,
Right.
BMI,
Yeah.
when are we going to have MCAS, when are we going to do, and so it starts adding up in terms
really
of competing
trying to fit it all
factors.
in.
And so it's great to get a sense from our administrators what they prioritize. So it's a great sort of point to think of is that, we have to continue to sort of look at our data and see is there more preventive stuff. Right now, currently, the majority of our colleagues do 7th and 9th
7th
grade.
and 9th grade. Right.
I just feel like the 9th graders are so young and immature compared to the 10th graders and the 11th graders.
And they are, and that's why it's really to get in there, because they really think about these things. They're thinking, and when we plant the seed, well, what would you do in this situation? You're not driving now, but in 2 years down the road, you're going to be getting into a car of other people. So what would you do in this situation? Yeah. So on the back of the card, there's our resources, and Jackie's right up there as Holliston Youth and Family Services. Amy Leone, who is in Milford, she's fabulous. She's come in and spoke to all our providers before. So we feel we have some good resources, providers to refer to if need be. So.
I'm also just curious about the older kids, because they are getting in the car and they're more independent and they're going and going.
Right.
much
Yeah.
more often.
And that's why it's good to plant the seed over and over when they're younger. Yeah.
A lot of our training that we had to attend was around this idea of adolescent addiction and at what point is the onset of it, and so when do you start recognizing symptoms to hopefully decrease the likelihood of adolescent addiction. And again, they kept talking about it from a health crisis, and so how
Right.
do we support
Right.
students? But that's not to say there aren't kids making risky behaviors in all
Right.
grades, and
Right.
so
And we like to say that that brain is still developing all the way until you're 21, 23, 25. And that's what we'll get into. We talk about with the marijuana and the same thing, with the legalization of recreational. It's not legal. 21. It's because your brain is still developing. There's a reason. Then you're more apt to make a better decision at that time, we hope.
I think another question that we've heard too is through the screening process, they don't talk about vaping in terms of
No, we don't.
substance use.
And it kind of skyrocketed soon after all this, I'm sure.
Yeah, it'll be interesting to see if they adjust it to
Right, the screening, yeah.
Yeah.
So.
Any other questions in regards to SPERT? All right, we're going to transition on then to Jackie Weiner, who is the director of Holliston Youth and Family. Jackie doesn't have a slide, but I'm sure she has a lot to share with us. So.
Yeah, and I, want to encourage, stop me as I go and share any reflections you may have. I appreciate you being here tonight. I know it's late. So I'm Jackie Weiner. I'm the director of Youth and Family Services. By a show of hands, how many of you have heard of Youth and Family Services? Wow, that's more than you typically get. Youth and Family Services has been in existence in this town for quite a while now. We provide individual therapy, family therapy, in-home therapy, short-term therapy, brief therapy. And we're really, we heard Tracy talk about protective factors early on in her presentation, and really, Youth and Family Services is there as a protective factor for this community, and it's there as a resource for you. And we try to be very good about sort of operating outside of the mental health system, which can put up a lot of walls for families. We're very good at follow-through. We're very good at calling back and answering any questions you may have. All of our clinicians are very good at assessment and giving good clinical recommendations. We work with youth all the way down to kindergarten, all the way up to, our oldest right now is 65. So really youth and families, it's all encompassing. We participate in many different initiatives in town as well. So I also co-chair the Holliston Drug and Alcohol Awareness Coalition. And so we are working all together to really think about sort of what is preventative, good preventative care, and how do we all work together to provide sort of a wraparound approach to children who may need more additional support. I'm a big proponent that all kids should have good mental health resources available to them. And I think one of the things that the SOS screening really does a nice job of is educating and bringing that education into schools. Because otherwise they would not have the language to be able to describe what's happening for them or what may be happening for a family member or what may be happening for a friend. And so the SOS is really a great way to start having those conversations. It really does begin at home. In order for the screening to have good, to really have an impact, it's really to think about it just as seriously as you would consider MCAST. It's a really important tool. It's a really important tool for parents to be able to have these conversations with their children. And we're happy to help and support you in having those conversations if you're needing some support in how to bring these questions up. As Tracy said, there's really no wrong way to be able to say, something's wrong. I see that. Getting really curious with them. You deserve to feel better is another way to sort of bring up that conversation. So Youth and Family Services is here, and we have flyers on that table over there. We're also having an open house on November 19th, and that's another opportunity for family members who may be interested in hearing more about our services to come and share some more to hear more about our program and to ask any other additional questions, to meet our staff. And so we're out there in the community, and we encourage you to take advantage of the services that are available to you. It's free of charge. We don't go through insurance. And so we're really able to be kind of creative and collaborative with the school in that way.
Do you want to talk about some of the groups you have running this summer or something?
Yeah, so we have a few drop-in programs we've done over the years. Over the summer, we did a drop-in expressive art group for middle school students. Right now, we run a drop-into art group at the high school every week. We also have a drug awareness program, and so that's a 4-session group focused around alcohol and drug use, where we can really look at sort of the frequency, the duration, the quantity of their use, and give them some really good self-reflective feedback on that. And we can also make referrals out if we feel as though we're not the best person to be working with that person. We really do want to make sure that we are understanding the needs and really assessing and making sure that we're providing good feedback. And so if we're not the ones to be able to provide that, we're going to find other people in the community that we trust and that we work really well with to be able to do that.
What about in-home services? Do you just talk about what that looks like? 'Cause that seems like a newer part of policy.
Yeah, so some families feel as though, they can't necessarily, there's a transportation barrier or there's an intensity there in terms of what's going on with their family member that would be best, the therapy would be best to happen in their home. And so typically what we do is we talk about, upon intake, just in terms of the logistics around that and if that would be appropriate and if you'd be open to that. It's one of my favorite things to be able to do is sit in your living room and talk about your family. It's a much more natural environment, and it's something that is, I think, really helpful for some families, especially when parents are working or there's a single mom, and parents want to be able to get their kids help, but they they're really stuck in terms of, being the barriers that kind of go with it. And so we're more than happy to get creative with you, whether it's coming to our office, which is located on 1750 Washington Street. We share space with Parks and Rec, but we're very separate from that part of the building. So families can feel very comfortable coming and feeling like it's discreet, it's all confidential. We don't communicate with the school unless you tell us you'd like that to happen. It's more helpful sometimes to make sure that all people understand kind of what's going on, but that doesn't necessarily mean that that fits for you. And so our services don't happen in the school for that particular reason. But we can go into the school and meet with a student if that's indicated. Do you guys have any questions for me? I'm curious kind of where you're at in terms of all this information.
And what are the different roles that they have?
So we all see clients, including myself. I'm full-time, and I have a 30-hour-a-week clinician. And then I have a graduate-level intern from Simmons College who's getting her master's degree in social work. So we're small, but we're mighty. And again, we're there to really sort of be, whether it's short-term or a long-term option, we're there to really partner with you and think about what you need. So really the first stop is just calling and asking us kind of, hey, this is what's going on. What do you think about this? And then we'll be able to really match you up in terms of my staff. Availability is another, factor that goes into it. But if not us, we will find you somebody, whether we go through Interface or another local provider in the area where we have a lot of partnerships with different agencies.
Before we were going to have a high school student stop by, I'm sure she got cut. It was very nice. But I did just want to mention, I think on the canary yellow paper over there, if you haven't heard about it and you have a child at the middle school or the high school, the BMC, the Beautiful Mind campaign, has been an extremely successful student group that we have here in Holliston and are very proud of. A former graduate of ours started the group several years ago, and then her sister had really sort of propelled essentially the mission for the group. And the focus, as you see on the flyer, is really about destigmatizing, or bringing down the stigma related to mental health and supporting students. They do a lot at the high school level during final weeks that we think there are high stress for students. They do a lot of sort of campaigning to support their peers and one another. Shauna Frost, who's the high school English teacher, facilitates the group, and they have about 100 or so students at the high school that join it. The middle school, I think, is in their first year or second year, I could be wrong on that, in terms of developing a middle school level Beautiful Mind campaign. And again, they're not sitting there it's not a therapy session, it's not heavy lifting talking about mental health, it's really sort of awareness and support to students in ways in which we can sort of increase positive culture and acknowledge mental health awareness within our school community. So just something to think of if you are looking to encourage your student to join a group at all. A school resource for us.
Is that Interface at the William James College?
That's it, yeah.
That's it. Yeah. Great. I'll post both Dr. Gladstone's presentation and Ms. Bowler's, and then we can send out information on Interface if people are interested. Any questions at all? I really appreciate folks coming out. Hopefully there's folks at home watching us as well too, but we want to just continue to sort of empower and educate and make sure you feel well aware and knowledgeable about the different support systems and screenings happening in our school system. Thank you. We'll be here for a little bit if you have questions off mic. Take care.
You can watch us on HCAT?
Yes, it will be on HCAT. I think on Loop we'll ask Mr. Gilfoy for sure, but we're on HCAT now, so beating through the universe. All right, thank you very much.
Thank you.
Feel free to check out, Jackie brought a lot of handouts for Holliston. So